Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humour and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
So, Dr. Matsumura, thank you so much for being here and joining us today, being our fourth muffin.
Oh, thank you so much for having me. This is going to be
We
fun.
have a ton of questions for you.
Yes, I actually have when we get into the question part, I actually had a patient this week, and somehow we got on to, I think she just asked me the question of like, so how do we dream? Why do we dream? And I'm like, I think it's REM. And I said, guess what? We're having a sleep specialist on. I'm going to ask her that question for you.
Fantastic.
And speaking of dreaming, you actually have something called the dream method, right?
I do. It is called the Dream Sleep Method, and every letter stands for a part of how I approach somebody's sleep. So, I try to bring this holistic approach because I think a lot of people in the sleep world, for better or worse, the way that our medical system is organized, we focus on abnormal breathing, but there's so many other things that can affect somebody's sleep. So that's why I developed.
Do you want to tell us a little bit
about it? What is it?
So dream, the D stands for daily habits. So what are you doing throughout your day that is helping you prepare, I would say, to be able to relax? Are you on the go all the time? Are you not giving yourself downtime? Are you eating enough? Are you drinking enough water? All of that kind of stuff. And then R stands for resting habits, or resting environment, rather. Resting environment. So is your environment dark, cool, quiet? Is it loud? Or do you live next to a really busy street? Do you have a 100-pound dog in your bed? Or a very loud partner who's snoring all the time? All of these things can affect your sleep. And then the E stands for emotions. We all know that anxiety, depression, PTSD, they affect your ability to get to sleep and stay asleep. A stands for the archetype, which is really your circadian rhythm. So are you an early bird, a night owl, falling into societal norm? And then M is for medical conditions. So do you have sleep disordered breathing? Do you have a hormone deficiency? Do you have an autoimmune disorder? Do you have a pain syndrome or a neurodegenerative disease that is affecting your ability to get into the right stages of sleep?
Yeah, I was on your website and I took the Sleep Goddess Archetype quiz. I thought that was really interesting. How do you use that in practice? Do you have patients go out and take it and then use it to help reset their circadian rhythms?
Well, I use it so that people know what their circadian rhythm is. So some people are not in tune with their circadian rhythm. We live kind of in an early-ish society. So if you're an early bird, that's a person who wants to go to bed before 9 o'clock, or by 9 o'clock. They're waking up around 4 or 5. The person who is a night owl, they love going to bed midnight, 1 a.m., 2 a.m., and then waking up at 8,
That's
9,
Eva.
or 10.
Yeah.
Yes. And then the person that kind of fits into societal norm, which is the Athena, is somebody who goes to bed at 10, wakes up at 6, goes to bed at 11, wakes up at 7. So the Artemis is the early bird, the Aphrodite is the night owl, and the Athena is fitting into societal norm. And, it's important because that's kind of one of the key elements around then developing somebody's plan for how we're going to strategize around helping them improve their sleep. Because if you're a person, a lot of people think that they're early birds. I mean, for God's sake, the New York Times comes out with an article that says that everybody should be an early bird. And so then you have everybody else who's not an early bird, freaking out over here in the background saying, oh my gosh, I got to wake up early. I'm not going to, get as much done. And there's, they're telling me that I might get, some sort of illness, when that's not true.
Yeah.
And I remember when that article came out, and I, was a keyboard warrior and told them a few things and said that, why are you doing this to people, causing anxiety? So.
And to find out who you are, is that kind of like your natural, if you were to go to bed at a natural time and wake up at a natural time, right? Because I would tell you, like, during my work day, I need to be up by 5 a.m. or 5:15. So I really strive to get to bed between 9 and 9:30. But if I were on a weekend and didn't have time, I would probably be like between 10 and 11 and up between 6 and 7. Like, that's just what my body would naturally do. And so when you answer those, are women supposed to, or people supposed to answer that based on, like, what would you naturally do if you were just to naturally go to bed on the weekend when you didn't have anything else to do?
Right. That's how you want to answer those questions. And that's why I put that as part of my method, because it is buried for some people. They've been living a different life for so long that they have no idea what their natural circadian rhythm is. And every single cell in our body is functioning on a circadian rhythm. And it's based on that core rhythm that is housed in your brain. We've got clock genes in our brain. That's what we're born with. We can fake them out, but we really can't change them.
I'm not 100% sure Rebbecca does sleep. I think she's got some vampire DNA in there, because that woman gets so much done in a day. It would take me 3 days to do what she gets done in a day. So I don't know if she does actually sleep at all.
Yeah. I think
I was
it's
just
different.
telling her, I don't know if you saw her posts on Friday morning. It was like she had gone to the gym, made breakfast. This is what I saw. Gone to the gym, made breakfast, went to a graduation, and then made it to work. And of course, got dressed in her magnificent closet. And I was like, are you kidding me? It was 8 o'clock in the morning.
No, I was like, that was last night.
But it wouldn't surprise me.
That's a lot.
I think when you have 6 kids and 3 dogs and your kids move back in and a full-time other job, there's just time management skills that you must have in order to do other things that you need to do. Yeah, that's all.
We're just
Life
jealous.
choices.
And hormone therapy, because when I wasn't on HT, I could not organize shit. So
I'm with you.
Yeah.
Yeah.
that was one of the skills I lost. It was devastating. And
So
sleep.
women always ask, like, what's the optimal sleep? Is that vary based on, I love it. I love the guest.
It's real life.
Based on your, is that vary based on your archetype? I know yesterday I did a lecture for a bunch of women, and I was like, look, you got to start putting yourself to bed. You need sleep. So treat yourself like you treated your kindergartner and get yourself to bed so that you can get enough sleep. So what are your thoughts on, optimal sleep in terms of number of hours, for example?
Yeah, so that's a loaded question, because women are, we're from an early age. In our society, generally speaking, everybody is lauded for not getting enough sleep. Burning the candle at both ends. I'll sleep when I'm dead. All of those kind of phrases, right? And then women specifically are socialized into thinking that it is the norm never to get enough sleep. Well, you're menstruating and you're in pain, or now you have children, or you're taking care of someone, or now you're in perimenopause. I mean, it's okay. It's okay. You're never going to get enough sleep. And I'm saying that because yes, the recommendation is to get 7 to 9 hours of sleep, but there is this new phenomenon that is now bubbling up called orthosomnia, and that is a fixation on getting perfect sleep. So then we are inducing more problems because people,
Stress.
you're on social media. It's sound bites, right? It's not truly, a medical consultation, right? So then you're getting all of these sound bites and your feed is flooded with, you should get 7 to 9 hours of sleep. So then you get fixated on that. And what I tell people is that every 15 minutes counts. So if you've been struggling with sleep and let's say you've only been getting 5 hours of sleep, but now you've made it to 5 hours and 15 minutes, that's a win. So every 15-minute increment of sleep gain is going to be a big benefit for you.
I love your approach, the way it's just so positive and stepwise and encouraging, and that everyone is a work in progress. And,
Yeah. And sometimes it can be really difficult, especially for midlife women, to have that positive outlook, I feel like, right? I think that there's something that changes in that. And so to turn that back to a positive is really, really great way of doing that. And that's probably a good segue, I think, into, one question I've had is, why is it in midlife or perimenopause where, sleep kind of starts to go like sideways and wonky? How much of that is hormonal? How much of that is not hormonal? Is it a conglomeration of both things that are going on in a woman's life during this time?
Well, that's in part why I did develop the dream sleep method, because I wanted to catch all of the things, right? And in fact, estrogen modulates melatonin. And the more research I've been doing around melatonin, if you have a reduction in estrogen, then you have a downregulation of estrogen receptors, which are modulating melatonin's release. That combined with all of the other things that estrogen affects, right? So you have all this, dysregulation around temperature control, around, your ability to get to sleep and or stay asleep. And so that alone affects women. And then you have this reduction in progesterone, right? So then you don't have that GABA effect that your body needs. And, both estrogen and progesterone also play a role in supporting the structures of the back of the throat. So then there's this increased potential in obstructive sleep apnea that happens for women once they have this reduction of estrogen and progesterone. And, that is, and then there's a stigma because we haven't made sleep apnea sexy yet, right? Like everybody loves wearing eyeglasses, even if they don't need them, because eyeglasses are sexy, right? We haven't made using treatments for sleep apnea sexy yet, but and not everybody needs positive airway pressure, so there's a whole host of things around that, I think
because those things are not sexy.
they're not sexy,
They're not.
right?
And I hear it every day.
Yeah.
They're just like, can you turn over to this big mask? Hey, honey, you want to get it on?
Right. Exactly. And there's all this trepidation when in fact, sleep apnea is an independent risk factor for heart attacks and strokes. So
Yes.
we really, and also it contributes to, you're not breathing in your sleep. So we want you to have high quality sleep. Even if you're not getting your 7 to 9 hours, at least the hours you are getting should be high quality. So I'm constantly saying you deserve to get better sleep. Let's help you get better sleep.
Struggling with mood swings, low energy, weight changes, or feeling dismissed about your hormones?
You're not crazy. You're in midlife. I'm Dr. Rebbecca Hertel, board-certified osteopathic physician and certified menopause practitioner. And at Osteopathic Midlife Health, I offer personalized concierge telemedicine for women in multiple states, helping you navigate perimenopause and menopause with expert care focused on hormones, weight, sleep, libido, and more. My approach blends evidence-based medicine with a deep understanding of longevity and precision midlife health. Because this phase isn't just about getting by, it's about thriving for decades to come. So visit www.osteopathicmidlifehealth.com and let's build your roadmap to lasting vitality.
And what are some other options for some patients who don't need the positive pressure? There are some other treatment options that might be available to them.
Yeah, so, women tend to have REM-related sleep apnea. So they will have clustered events of abnormal breathing during REM sleep. So that averages out to either low, moderate, or high, mild sleep apnea, which is a perfect indication for an oral appliance. So oral appliances are much less, invasive in terms of, the mask. And there's a lot of different types of masks, but let's face it, they're all made for men's faces. So oral appliances really can work quite well for a woman and improve the quality of sleep, improve oxygenation, and then you get into all the right stages of sleep because it's all this vicious cycle. I mean, if you don't have enough melatonin, then you're not getting into the right sleep stages. So your sleep architecture, that's what we call it, you're not getting all of the right stages or enough of the right stages of sleep. Same is true if you're not breathing in your sleep.
And if you're not breathing properly during your REM sleep, and we know REM is a very important part of sleep, that's really detrimental, isn't it, to your health?
Yes.
So, what are your thoughts on supplementing melatonin? Should women be doing that? Is there a dosage? Or,
Yes.
because when estrogen's low, melatonin is low. I think I saw something on your website that I was like, oh man, maybe I shouldn't be taking as much melatonin as I take.
Right. So there, of course, in the United States, we have no regulation of supplements. And so that's why I did a post recently on making sure that it's third-party tested and then understanding why you're taking what you're taking, right? I say that all of the time to my patients. You don't need a whole lot of melatonin. So all of the melatonin that's sold out there, that's 5, 10, 15, 20, that's just too high. So we only need 1 to 3 milligrams of melatonin. And there is some data that's being published now finally around sustained release. And sustained release mimics our physiology a whole lot better, and it's keeping people asleep. So the immediate release melatonin helps people fall asleep, but it's not really helping people stay asleep. So the sustained release, again, is mimicking that how melatonin's curve stays elevated, and then you finally have a washout period when you're waking up. I'm probably going to get a lot of shade from other sleep docs around promoting melatonin, but the more research and deep dive I do, the more I'm convinced it may be the next, hormone like vitamin D, how we all came to understand that we need vitamin D. I really think that melatonin is part of this enhancing your lifespan and the longevity of just improving longevity. I really think that it is a missing link because if you don't have enough melatonin, then that affects your sleep architecture and you have more oxidative stress. So then you have deterioration of cells at a faster, more rapid rate. And then it just kind of builds on itself. And by age 50, we have almost 50% reduction in melatonin production.
And when you look
I guess
at
that
a
makes
graph,
sense, right? If it's related to estrogen.
it starts to fall kind of around the same time as our progesterone starts to fall, doesn't it? So it's like a double whammy because that progesterone is so important for us getting to sleep as well. So it's no wonder half the country is up at 3 a.m. in the morning, haven't been unable to get to sleep. But
Yes. Yeah.
So would that be something to add where, I usually will start progesterone or estrogen, in these midlife women who need it. So is it progesterone first versus estrogen? If they're having sleep issues, progesterone's definitely to play because of that calming effect and ability to fall asleep. But It's interesting because is that keeping them asleep, or is it the need to add some of that sustained release, low dose
Yeah,
melatonin to keep them then
right.
asleep?
So, progesterone, I think, what I have read is that it is really helping you with sleep onset, but it's not necessarily the maintenance of sleep, right? It's not keeping you asleep. It is really the estrogen component and the modulation of melatonin that is actually helping sustain sleep throughout the night. So, what I would say is, or my approach is, if somebody comes to me and we do this full evaluation and we start out on hormone therapy, and then you are still having problems sleeping after we feel like we've arrived at the right dose, right, of your hormone therapy, then I say let's start with a deeper evaluation. We may need to do a sleep study, whether or not it's in a sleep center or a home study. That's fair game at any part of this evaluation. But when we think about supplements and medication, I will first start hormone therapy. And then if I'm not making any headway with the sleep, then we do a deep dive evaluation. And that's when I would say, maybe we should try melatonin. And I'd say a third of my patients continue to have problems sleeping. So it's a little combination of a lot of things. And, when we think about insomnia, chronic insomnia is a specific condition, right? And the only true successful treatment for chronic insomnia that's been studied is cognitive behavioral therapy for insomnia. And we always want to use that in concert with whatever supplement or medication we're using. I am not a person who prescribes medications for sleep that are prescription medications. The fine print for every single one of those medications says not to use it for more than 2 weeks.
So many women are coming on sleep medications, and I tell them, I'm like, we're getting you off that stuff. I'm like,
Trazodone. It's like
all the time.
handing it out like jelly beans. Just take some trazodone.
And they're not sleeping any better. They're not sleeping any better, except they're
Yes.
complaining that they're so groggy. And the other thing that I've been seeing more and more of, and especially on social media, and I think it's the understanding, I think a lot of clinicians don't understand that progesterone gets you to sleep, estrogen keeps you asleep, is that I'm seeing people are just escalating on progesterone and not estrogen. And so women are on 3, 4, 5, 600 milligrams of progesterone. I'm
Makes
like,
my boobs hurt when you say that.
I don't know how they're functioning, because I tried once to take 300 milligrams, and it was a really bad day because I actually went on site somewhere to do menopause care, and I felt like my whole day, like my head might as well been inside an HVAC. Like I was like, oh God, why can't
Right.
I? Like everything was like, So what do you think about, all these providers that are just escalating on progesterone and people are walking around like zombies?
Well, I would like them to think about the fact that maybe they need to see a sleep specialist and maybe somebody else needs to take a look. And, it's all the nuance of care, right? There's no one just, easy prescription. I'm not saying that every single person needs to be on melatonin, because frankly, there's a lot of, people will say, but I have nightmares, because that is a side effect. And for some people, it's quite dose dependent, and it could even be a small dose that makes them have nightmares. It should not make you feel groggy in the morning. But to your point, I have, people come to see me with loads of medication, right? They come in, with their $300 a month worth of stuff. And I start talking about scaling it back, and immediately they say, no, I can't sleep without it. And I have to say, now hold on. You came here in a consult because you can't sleep. So all this stuff isn't working, right? I mean, you just told me you have this elaborate 3-hour plan to help you get to sleep and you're still feeling like you're not sleeping because that's why you're here. So these aren't working for you. Right?
I find that really interesting, the way you say that melatonin is kind of released in a curve. I did not understand that.
Yeah.
I actually thought you got a little bit of a spike of melatonin around the time we're supposed to start getting sleepy and ready to go to bed. So that's so interesting that they're thinking of doing this slow release melatonin, which sounds like it would suit our bodies much better.
Well, it's a chronobiotic, so it's not a sleep aid, but it is sold as a sleep aid over the counter. So it actually starts the cascade of sleep. So it's a pretty complex mechanism because we have these ganglion cells in our eye that directly connect to the suprachiasmatic nucleus that's in the hypothalamus, and then that then sends a signal to the pineal gland, which is behind the third ventricle. And, you know, all this stuff is happening. So we release melatonin on average around 4 or 3 hours before we actually hit the pillow.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
So if we're going to take it as a supplement, you want to take it 2 hours, 1 hour before you fall asleep, or you intend to fall asleep. And that is if somebody is following their circadian rhythm and they're having trouble getting to sleep and staying asleep. Now, if somebody needs to realign their circadian rhythm, so let's say somebody who's a night owl, but they have to get up really early for a job, that's a totally different story. So this is not about circadian realignment. This is simply replacing what you have lost. We've heard that before, right?
Yeah.
Right? This is replacing what we are losing to help us get some sort of balance, because we'll never get to that point where we were before we lost it, but we'll get to a point where we're at least not feeling all of the symptoms.
And could you talk to us a little bit about what does alcohol do to our sleep architecture? There's a part of me that doesn't want to know this, but
That's the saddest thing in the entire world.
I know.
I know.
Here we are.
I think we need to know. We need to know.
That's a party pooper question. Anyway, I'm with you because, of course, I just can't handle alcohol anymore. And so I kind of think that maybe when we were younger, we just drank so much that we just didn't even notice that we weren't getting any sleep, right? Right?
Yeah,
We weren't even
probably.
noticing. And now we're better about it, but we drink just a little too much and it just messes our sleep up completely. And then you have to make up for it. You lose an entire day. So the half-life of alcohol hits right in the middle of people's sleep typically. So if you're drinking alcohol in the evening, you're at a party, and then you go to sleep, 4 hours later, which is when you're supposed to be hitting your biggest your biggest segment of REM sleep, that's when it starts to cause all of this awakening, and it really interferes with REM sleep. So that's why you think, I didn't get any sleep at all, even though you feel like, well, I felt like I slept, a good, amount of time, but it doesn't feel rested because it was disrupting your REM sleep, which is when, all of the emotional processing is taking place and the consolidation of the day has happened.
And you can really feel it, can't you, girls? Like it just, you have those wake ups throughout the night. You might have been sleeping
toss,
great,
turn.
and then yeah.
So here's, I know everybody wants to know this. Why is everybody up between 1 and 3? Why is it those hours?
That's a good question. I haven't really done enough digging on why specifically it's those hours, other than kind of connecting dots. And so those dots would be, is that when we don't have enough melatonin production, that it's not sustaining sleep? Is that when our body then got used to it, developed like a new highway in the brain when we were having this dysregulation from a reduction in hormones, if you're talking about midlife, right? Did our body then accommodate, right? And say, well, we know we're going to wake up anyway, so I'm just learning this new pathway, and I'm anticipating, even though it's over, I've learned a new pathway, and I'm just going to stick with it. And you have to retrain your brain. You have to tell it, you can get rid of that pathway now. That's where cognitive behavioral therapy comes in for insomnia. Right. That you have to retrain it. You have to say, nope, I want you to start using the original pathway when I was actually getting better sleep. That's the neurological pathway I need you to start using. I want you to forget about this learned pathway so that's why there's all this, controversy around medications versus cognitive behavioral therapy for insomnia. But simply, we just really haven't done enough research on melatonin, and it's scary. Just like vitamin D was. I remember when vitamin D started, hitting the scene as a necessary hormone, and there were some naysayers, and there was all this initial controversy, and it was simply because we didn't have enough data around why is it that we need to replace it, why is it that we need vitamin D, and melatonin is a hormone. It's not a mineral, it's not a it's a hormone. It's hitting a lot of different things in our body.
Yeah. One of the things I found really interesting when I was doing some research on osteoporosis is that 3 milligrams of melatonin is good for bones.
Yeah.
Yeah, which once I found that out, I felt a lot less guilty about all the melatonin I take.
I don't want to know how much melatonin.
Try the sustained release now.
No, I love it. It just goes,
just use your fingers.
That's how I fall asleep.
Can we touch just a sec on that magnesium, particularly I think the glycinate, although I do the threonate at night. I don't know, maybe I shouldn't, but there's a lot of talk around that, the different types of magnesium, which, are good for different things. And I will have women that come to me, they're like, I started magnesium glycinate, I sleep great. I'm like, okay.
Yeah, it enhances relaxation, muscle relaxation. That's all about the electricity, like your positive and negative ions, and that's really the focus on magnesium. And yes, there's different types of magnesium, but honestly, sometimes people will say, well, I started on this one and it works. I'm like, great, I'm not going to change it.
Keep going.
But yes, the data is out that yes, magnesium glycinate is the one to go, and that's that is it's a compound, right? So it's that is the one that tends to be the most active in terms of relaxation centers to help you actually then get into falling asleep. So it helps with getting to sleep. It doesn't necessarily help with staying asleep. So that's the thing.
Right. So still the calming effect.
It's really the calming effect. And it's so low, it's water soluble. So, you take a little too much, you might have diarrhea, but okay.
As long as you're not taking meg citrate, right. Then you'd be really.
Well, that's explosive.
Unless you need it.
That's explosive.
Unless you need it.
But that's what I always would tell. That's what I tell people. Calcium constipates, magnesium makes you move. So right.
I tell my patients, when the bottom's falling out of your world, take mag citrate and let the world fall out of your bottom.
Oh my gosh, I've never heard that. That's
I love it.
That's a cute little mnemonic.
Oh, and then I did promise my patient, why do we dream?
Yeah.
Do we? I know it may not be a quick explanation, but she's like, why do we dream? So I said, well, I have just a person on our podcast.
Well, REM sleep is really important for emotional regulation, and that's why we dream. So when we are in REM sleep, that's when we're doing majority of dreaming. There is some data that's coming out that's some like your deep stage of sleep, which is N3, you may have some, but I'm not convinced yet because there's not enough data, right? So, but N3 or your slow wave sleep, or for people who use wearables, right? Because almost everybody has a ring or a watch or something. So something on your body is called a wearable, something that you put next to you or that you sleep on, because a lot of people use their phone, right? That's called a nearable. It's not as accurate. And in fact, the most accurate wearable is only 75% accurate. So I think it's okay for trends. I don't think that it's fabulous for, it hasn't hit the market for diagnostic testing yet, right? But slow wave, so when you think about sleep, and I now describe it based on how people are looking at their data, right? So you have light sleep, deep sleep, and REM sleep. And so your deep sleep is the physical restoration. That's where all of the physical components are, that's when your growth hormone is released. That's when you're repairing physical health and doing some memory consolidation. But REM sleep is really all about emotional regulation and consolidation of memory. That's why you're dreaming. A lot of times there's things that have happened in the day or things that are going to happen that you end up dreaming about. And you do not have to remember your dreams to dream. To know that you are dreaming, right? Mm-hmm. So a lot of people will come to me and say, I haven't dreamt for 2 years. And I would say, well, then you would not be alive talking to me. Like, in order to survive, you have to dream. So
that's so interesting.
Fascinating stuff. I think dreaming is fascinating. Yeah.
I would just like if less of my dreams were about open water and fish.
About what?
Open water and fish.
Oof.
Yeah.
Huh. I
don't like the dreams where I'm like running. Are you flying? I'm running like away from people, like in circles, like trying to like hide and run away from someone. Like, so, and then you wake up, I'm like,
Christine, wait a second. Are you flying like
like you're flying yourself?
Like Supergirl?
My arms jumping.
My God.
I don't know what that means.
That's
fascinating.
That might mean, kind of goes with the concept that you're building the plane as you fly it. So maybe you're building something pretty cool. Maybe something's happening.
She is. She's building lots of things.
As long as they don't just fall.
Yeah. Or when you trip. I love when you trip and then you wake yourself up.
Oh,
yeah.
Yeah. Isn't that fascinating? We all dream something a little bit different.
When people have sleep apnea that isn't diagnosed, one of the classic dreams is that they're underwater, that they can't breathe, that they're struggling to get out of from underwater.
Yes, that makes sense because you're suffocating.
We should probably ask our women a little bit more about that.
Yes.
Right? Mm-hmm.
Any advice on sleep testing? I think sometimes people are apprehensive about going. I know there's, you could do home study. Well, let me ask this question. Who is a good candidate? Who needs to be in office versus home study? And what are some advice about getting yourself through it if it makes you a little anxious thinking about people watching you sleep?
Well, okay. So, home study versus in the sleep center sleep study, there are specific clinical indications if somebody needs to be in a sleep center. So if maybe you have a lung disease or a heart disease or a neuromuscular disorder, like people who have ALS, they just need to have an in the sleep center sleep study, even if they don't really have any symptoms quite yet, right? Because they have a tendency to hypoventilate and they don't realize it when they're sleeping. People who are very symptomatic and they have a negative home sleep study should have an in-lab sleep study. And, that's really important because women tend to have a higher false negative rate. And so, really we should figure out a way to refine testing so that people can either do it in their home. And there are certain levels of testing. So everybody knows about the in-lab testing versus the home sleep testing. In-lab testing is called a type 1 study. A home study is called a type 3. But there is one in between that you can still do at home called a type 2. And the reason why they're not as popular is because they pay out the same as a type 3. So you're not getting more, so there's a reason why, but it does capture more data. All this to say, women have a higher false negative rate because, again, they tend to have REM-related sleep apnea. We can't really capture REM as accurately as we can in an in-lab study as we can in a home study. Now, there's some home studies that are really touting the fact that they can capture all stages of sleep, and that's cool. That's great, but they still have a higher false negative rate, especially when it comes to women, because, again, women tend to have lower, levels of sleep apnea. So we might not catch it all. So,
Right.
There's this endless debate. Should we do 1 night? Should we do 2 nights? Should we do 3 nights? And I really think the more that I've been reading about it, because I practice one particular way, because that was the constraints of a practice, right? Where everybody got 1 night. If it was negative, we'd, lobby with the insurance company to do a second home night, or we'd bring them into the sleep lab if their insurance allowed us to, right? Because, insurances don't really care what we think. So now in my own private practice, I'm probably going to do a multi-day home study because I think that you get better data that way. And then you can really see what's happening in a person's night. And I'm looking at home devices that really have information specific to data around women, to outcome data around women. And again, that's because they have mild sleep apnea for the most part, but it is severe during REM sleep. More so, not everybody, but that tends to be the pattern. And you don't always capture that in a home study. So I've had many women come to me and say, well, I was told I didn't have sleep apnea. So then I evaluate all the data and say, you know what, let's do it again, but we're going to do it this way. And then we capture it. And maybe, apnea hypopnea index is just one way. That's one type of sleep apnea, and of course all the studies are done mostly on guys, right? But, I'm convinced that there are other phenotypes of sleep apnea that we have yet to discover that might be really gender specific, but we're not looking for those because we can't get treatment covered for those.
It's so important, especially the way so many of the studies are done on men compared to women. So I love that you're going to focus on that. You're opening your own practice here in Oregon at the end of the summer, right? Will you tell us a little bit about that? I'm going to be your first patient. Will you tell us a little bit about that, and also where our listeners can find you on social media and the internet?
Yes. So I will be opening up my private practice where everybody gets to go through the dream sleep method. And you get a plan, a toolkit. You may get a sleep study. Not everybody needs a sleep study. And, just a little bit more about that. There aren't any really great screening tools for women to see whether or not somebody's at high risk for sleep apnea. I mean, the stop bang that is used widely, one of the questions, the G, is what's your gender? Okay. So if you're a guy,
right.
If you're a woman, you already have minus a point. And that could have been the threshold to get you a sleep study, right?
Oh my God.
So we have yet to find a really great screening tool, especially for women around ruling in high, pretest probability for sleep apnea. But yes, so I will be doing, I will have a private practice. I'm working on having in-person 1 day a week, and then the rest would be virtual. Typically that would be follow-up visits virtually, and that's going to be happening at the end of the summer. And I forgot what else you asked me.
That's exciting. Tell our listeners where they can find you.
Oh, yeah. My website. So I'm Sleep Goddess MD. I love Greek mythology. And so that's what I want for everyone. I want everyone to sleep like a goddess.
Oh, I love that.
Thanks for joining us today,
Thanks so
Andrea.
much,
It's been
Andrea.
such a pleasure to have you.
Oh, thank you for having me. This is fun.
Yeah, we're so happy to meet you finally.
Yes, so for all our listeners, follow Dr. Matsumura online. And if you're living in Oregon, you can start to see her at the end of the summer.
Yes. All right. Thanks.